Welcome to another Drug Chug episode. Today, we'll talk about steroids and how they work, specifically anti-inflammatory steroids, also known as corticosteroids. This video has a lot of information, but we'll unpack it quick and effectively together. These are the sections outlined throughout the video. There'll be timestamps down below and a short quiz at the end. Let's do a quick overview of steroids before we jump into the details. So we're talking about anti-inflammatory steroids. These are also known as corticosteroids. And that's a crazy word, so let's break it down into two pieces. We have cortico and we have steroid. The steroid side just means it's a hormone. And your body has a bunch of different types of hormone. Some people think when they hear steroid, muscle growth steroid hormone. We're not talking about that. We're talking about hormones that primarily do anti-inflammation. So that's a good distinction to know throughout this video. So then let's focus on the word cortico. And cortico actually comes from the word cortisol. And cortisol is a hormone your body produces under stress. A lot of people have heard about cortisol releasing. And what it does is there's a bunch of processes your body needs to either optimize or adjust or stay in homeostasis. And cortisol actually has two primary effects. The first effect is the glucocorticoid effect, and this is where we're going to focus most of our time on. This is the effect or the pathway that most of these drugs are made for. So the glucocorticoid effect has a bunch of different downstream effects. And what I mean by that is when we enhance the glucocorticoid effect or the receptors, they can control inflammation. They actually have immune function response, and they also regulate the metabolism of your liver, like raising glucose. We'll talk about these in detail, but just know the glucocorticoid effect is going to be our biggest driver for pharmaceutical effects. And we have a mineral corticoid effect. Here, it primarily regulates electrolyte balance, so sodium and potassium levels. We'll talk a little bit about this in detail, but majority of this video, again, we'll talk about glucocorticoids. And because there are so many glucocorticoid effects, it makes sense that there are different dosage forms for these medications. The first one, we've seen creams and ointments for inflammation. These corticosteroids can come in this form, and we've seen hydrocortisone as a popular option. We also see oral dosage forms, so all the tablets and capsules. A popular one is methylprednisone. They usually come in these dose packs. We can also see these steroids in inhaler form or intranasal form. Both we've seen as Symbicort or Flonase for allergies and asthma. And then we've also have the injectable versions of these drugs when we talk about higher levels of care in a hospital. So we've seen injectable IV medications that are steroids, and a popular one is Dexamethasone. And most of these corticosteroids, if you've noticed, they end in either izone or azone. So prednisone, dexamethasone. So when you see this, there's a good chance we're talking about a corticosteroid. Now that we have a good general understanding of glucocorticoids, let's get in a little bit deeper. Let's talk about the mechanism of action. So let's talk about our natural glucocorticoid, cortisol. And the way cortisol is actually made and released is through the hypothalamus, which is in your brain. Basically, the hypothalamus releases another hormone called ACTH, which travels to your adrenal glands, which are on top of the kidney, and that produces cortisol and releases cortisol. And remember, cortisol is your natural corticosteroid. And what's unique is when we have more and more cortisol, it's actually a negative feedback loop, meaning when we have more cortisol, it links to the hypothalamus to say, hey, stop making more cortisol. So this is a natural negative feedback loop. So all you really need to know is that your hypothalamus is telling your adrenal glands to release cortisol in certain stressful situations. So now we have cortisol in our body. But how does cortisol actually affect our body? Well, when you have this cortisol release, it attaches essentially to two receptors, the glucocorticoid receptor or the mineralocorticoid receptor. And we'll be focusing on, yeah, you guessed it, the glucocorticoid receptor. And we have three major pathways that these bindings of this receptor actually work. The first one, it actually inhibits these pro-inflammatory receptors and intermediates. We have a bunch. We have phospholipase A2, IL-6, which is interleukin. We have TNF alpha, which is tumor necrosis factor alpha. There's a bunch. But essentially, the cortisol inhibits these intermediators. And when it inhibits these intermediators, we get decrease in inflammation, right? That's the biggest purpose of making drugs that mimic cortisol. We decrease inflammation. So that could be on your skin, in your lungs if you have asthma, if you broke out in hives. There's a bunch of different types of inflammation. The second pathway that we see cortisol or these steroids work is through our immune system. We see these corticosteroids inhibit our immune cells like T cells and B cells. And what that does is it decreases your immune response. And look, that sounds really bad. Sometimes it is, but sometimes that's what we want. If you have a patient that's a transplant patient, let's say they got a new heart or new lungs, you're going to want to decrease that patient's immune response so its body doesn't attack the transplant organ. And there's a bunch of different examples. We'll talk about them, but just know that these glucocorticoids, one of their effects is to lower the immune response in a patient. And the last major pathway we'll talk about is when these glucocorticoids reach your liver, they're able to make your liver release glycogen, which will break down essentially in glucose. So we have an increase in glucose, right? And that kind of makes sense. If cortisol is a stress hormone and you're stressed out, essentially you're going to want some sort of boost in energy in a way, and glucose is a form of energy. But this is something you need to watch out for, because what if your patient is diabetic, right? What if they're trying to control their glucose levels? It's something to monitor. But again, we'll talk about that in detail later, but these are the big three pathways when we talk about glucocorticoids. And as a bonus, let's just talk about mineralocorticoid receptors real quick. And essentially, when we have a mineralocorticoid receptor, it will bind and cause sodium and water retention, some potassium excretion. So essentially, that fluid and electrolyte balance that we talked about earlier. And this is a good baseline to understand how these drugs work. And we'll talk about this again in more detail. But basically, when we have a corticosteroid, we can have that drug either favor the glucocorticoid receptors or the mineralocorticoid receptors or both. Now that we know how these drugs and hormones work, when do we actually use these corticosteroids? Well, the first one is inflammation. We talked about that. So that's essentially kind of like tissue damage. You have redness on the skin, irritation. So we can use either creams or oral products to help reduce inflammation. Then sometimes we see during allergic reactions, right? When a patient has hives or anaphylaxis, which is very serious, basically the throat could be closing up because of an allergic reaction, we can use these steroids to help reduce those inflammatory processes and reduce the allergic reaction. Then we talked about asthma and COPD, right? Patients that have asthma or have COPD use inhalers. And majority of the time, not always, there's going to be a steroid in the inhaler. Next, we talked about autoimmune conditions. We can use steroids in various autoimmune diseases. And we talked about how steroids reduce your natural immunity. So, patients that have Crohn's disease, multiple sclerosis, lupus, these are all disease states where your own immune system is attacking itself. So, when we use steroids, we reduce the immune system. So it prevents or at least reduces the attack of itself on its own body. Another use of glucocorticoids is actually in cancer treatments. Sometimes we'll see it used as part of a regimen. Sometimes you could use these steroids as a pre-med. It's just something unique in this class to know that you can actually use it for cancer. And for our mineral cocorticoid functions, we want to talk about adrenal insufficiency. This is when we use the mineral cocorticoids, and the biggest reason is Addison's disease, which is basically the kidney not being able to filter in and out and balance electrolytes properly. So we would use a mineral cocorticoid to help the body regulate that electrolyte and fluid balance. And there's so much more that we can't talk about because I could spend another 2 hours just rambling off. But just understand that glucocorticoids have a lot of uses, right? We talked a bunch here, but we didn't even get into the pediatric or the NICU side or the emergency medicine side. There is a lot. When I say a lot, there's a lot of uses when it comes to corticosteroids. So now that we know when to use steroids, let's talk about the actual dosing and adjustment. I'm going to warn you, there's so much information here. Please do not try to memorize it all. Maybe consult with the pharmacist, but essentially, we're going to talk through this, so don't get scared. So here is a list of the more popular corticosteroids. We kind of talked about some of them. We talked about the actual drugs, right? We talked about, let's say, prednisone, methylprednisone, dexamethasone. These are very popular steroids. And the way we actually talk about corticosteroids is relevant potency, meaning how much stronger or weaker is this drug compared to hydrocortisone. So hydrocortisone, you'll see it's a one-time relative potency, meaning it's the same strength as hydrocortisone. But then we'll go up to prednisone, meaning it's 4 times stronger. Then we'll talk about methylprednisone, which is a little bit stronger than that. And then we talked about dexamethasone, right? Our big boy drug, 25 to 30 times stronger. And this is important. Sometimes we'll talk about converting from one to another. So the pharmacist essentially has to figure out what the equivalences are. And then we also talk about the mineral cocorticoid activity. Because remember, it can do both glucocorticoid and mineral corticoid. So here we see high, moderate, low. It really depends on what you're trying to target and what you're trying to apply to that patient. Common dosing ranges, they all vary. It depends what you're treating. Prednisone here shows anywhere from 5 milligrams to 60 milligrams a day. That's a big range. Methylprednisolone, right, 40 to 80 a day. We have both IV pulses, and methylprednisone can come in those dose packs where it tells the patient, take 8 the first day, then 6 the next day, and 5 and 4 the day after, right? So it's very unique and diverse. It really helps an outpatient. Then we talked about dexamethasone. Here I want to highlight that it comes both in oral and IV, and so does methylprednisolone. Some of these drugs that only come oral are good for patients that want to pick up a prescription. Some of these that are IV, right, we're going to see it more in a hospital setting, emergency setting, right? Now, I just want to highlight to you guys that there's a lot of information here. Don't memorize it, but just understand that there are strengths, there are relative potencies, there are different common dosing ranges. Some come in oral, some come in IV, some come in both. So now let's talk about side effects. And glucocorticoid receptors are everywhere in our body, right? We talked about how much they can do. There's a lot of functions that they help with. So it makes sense that these drugs can cause a lot of side effects. And you always want to assess the risk versus benefit in each patient, right? Does it make sense? Do the risks outweigh the benefit, or does the benefit outweigh the risk? You want to talk about duration of therapy. Is it going to be a 1, 2, 3 day thing? Or are we talking about a 7 day course, a 14-day course, or longer? And obviously the dose of the steroid. Before we talked about how many different ranges of drug you can have, right? Prednisone, we said, was 5 milligrams all the way up to 60 milligrams. So the dose also matters. We need to take account for all of these things because the larger the dose, the longer the therapy, the more risk for the side effects that we might see. And with that, let's talk about our first one. Weight gain. So our first side effect is weight gain. Anytime a patient starts a corticosteroid, there is a chance that they'll gain some weight, but once they stop, obviously it's reversible. The second side effect is fat redistribution. Here, it's actually called Cushing syndrome or moon face. It's not that they're gaining weight, it's just that the hormones or these glucocorticoids cause your fat, your adipose cells, to actually move around and relocate, and then it will cause that moon-shaped face. We also see edema as a side effect, right? This is where fluid buildup in the legs or the extremities are shown, and again, this is also reversible. But then we talk about osteoporosis, and this is the softening of your bones. And this usually happens over a long period of time, right? This isn't something if a short course steroid is used. This is if a steroid is used for months and months and months. You want to watch out for patients that are older that already have osteoporosis. Next thing is altered mental status. These hormones might affect the way a patient basically thinks or acts. So it's something to note, to monitor, because their behavior might change. Then another side effect we talked about was hyperglycemia. One of the effects of cortisol or these steroids is to go to the liver and release the glycogen stores to cause and break down more glucose in our bloodstream. The next side effect is hypertension. We do see sometimes an uptick in a patient's blood pressure. One thing to note is peptic ulcers. We do see some patients that stomach lining weakens, and we do see peptic ulcers develop in the patient's stomach. The next thing is an increased risk of infections. And we talked about this one. Basically, steroids lower the immune response. And when you lower the immune response, you're more exposed to infections, like let's say the common cold or the flu or whatever it might be, because you lowered your immune system. And the last one I want to talk about is adrenal crisis. And remember when we talked about how cortisol is basically created in your body and released? Well, what happens is because we're artificially giving glucocorticoids and you constantly are suppressing that cortisol production because you're artificially giving more, so your body isn't going to be making more cortisol because you're getting it from the outside. And then you just cut cold turkey, you stop taking the corticosteroid, it causes this adrenal crisis. And this only happens when there's an abrupt stop. And typically, you want to taper off of the medication if it's more than 7 days or 6 days, depending on the dose. But if the patient is taking a long course steroid, more than 6 days, we'll call it, you want to have them taper off at the end of the regimen. All right, we made it to the end. So let's do a quick summary and then take a short quiz at the end to see what we retained. We talk about corticosteroids, and we said how there's a glucocorticoid receptor and a mineralocorticoid receptor and how they do different things. We also said how the corticosteroids come in cream, tablets, capsules. They come in inhalers. They come in injectable forms. There's a bunch of different forms that these drugs come in. Then we went in specifics. We talked about what the glucocorticoid receptor does, and we said it decreases inflammation, it decreases the immune response, and it can increase your blood glucose levels. We also slowly talked about the mineralocorticoid and how it has sodium and water retention and potassium excretion, basically that fluid and electrolyte balance, specifically used for Addison's disease. Then we talked about dosing a little bit and how to look at dosing and not memorize it because there's so much information. We talked about the natural cortisol, hydrocortisone. We talked about prednisone a little bit. We talked about methylprednisone and our injectable dexamethasone. Then we talked about when we use these actual medications, and the biggest one is inflammation. We talked about allergic reactions. Patients that have asthma or COPD use these corticosteroids, and any autoimmune function. And then we talked about side effects. There were a lot. We said how it can cause weight gain or fat redistribution. There's edema or swelling in the legs, osteoporosis if it's used for a long time, along with altered mental status, so checking that patient's behavior, hyperglycemia, hypertension, some peptic ulcers could arise, that increased risk of infection, and then adrenal crisis if you do an abrupt stop. I know it's a lot. That's a great foundation for corticosteroids. Let's do a short quiz to see what we retained. Which of the following is a well-known adverse effect of chronic systemic glucocorticoid use? What is a common sign of a iterogenic Cushing syndrome from chronic glucocorticoid therapy? What is the main reason a glucocorticoid taper is required after prolonged therapy? What bone-related preventative measure should be considered for patients on long-term glucocorticoid therapy?